Huntington's disease was the first medical condition where a preclinical genetic diagnosis was possible. Now, what does that mean? Well, what this means is that before symptoms even manifest in a patient who's almost certainly going to develop the disease, that patient will become aware of the knowledge that they will suffer through a physically, a psychologically, and a socially devastating disorder, as some experts have referred to it. Often, a patient will live 2 decades from when the symptoms first begin and when the patient will eventually pass away. 2 years to deal with the progressive degenerative changes that occur within the central nervous system. While that sounds horrifying, it gives the treating physician and the patient ample time to treat any symptomatic concerns. And one day, this might mean that a patient could live long enough to witness the development of a cure. Hey podcast listeners, Jim Siegler here for Brainwaves, recording from Studio 3 in Philadelphia. And this week on the show, completing our 2-part series on Huntington's disease, we're talking about the current and emerging therapies for this neurodegenerative condition, from anxiolytics to nucleic acid-based therapies. Stay with us. I'm joined in the studio this week by Dr. Stephen Arati.
I'm currently a third-year neurology resident at the University of Pennsylvania. I'll be pursuing a movement disorder fellowship with a focus on Huntington's disease after graduation.
Steve, what is the one way you would summarize the treatment of Huntington's disease?
So right now, in a broad sense, the treatment of Huntington's disease is aimed at reducing the impact of the disease on a patient and their family members and caregivers. That's a very kind of general statement, but I think that it applies. This treatment looks different throughout the different stages of the disease, from at-risk to pre-manifest, and to the various stages of manifest disease. This is broad and incorporates symptomatic therapies, which can be pharmacologic and non-pharmacologic, as well as supportive initiatives to address psychosocial and economic impacts of the disease. As a principle, robust management of HD depends on a proactive approach involving multiple disciplines. I'd also add that this includes connecting patients and families with active research involvement opportunities should they wish to participate. One of the most inspiring aspects of this patient population is that they're generally highly motivated to contribute to efforts to develop new therapies to alleviate the suffering of this disease. This is especially true right now as we're moving into an era where for the first time, we're studying disease-modifying therapies on a large basis.
And we're going to get into exactly what these disease-modifying therapies are and what's currently in the pipeline. But for the most part today, Dr. Arati and I have focused on the multidisciplinary supportive therapies that target patients' symptoms, and especially the role of the patient's support system, family, and friends, the role that these people play in the care of a patient with Huntington's. Not to sound kind of harsh or get too far into some of the sadder details of Huntington's disease, but what is it that patients with HD usually die of, and what should we as neurologists be aiming to prevent with treatment?
I think it's a good question. In terms of raw numbers, when we look at some of the larger studies that have been done looking at mortality in Huntington's disease, in terms of the cause of death on death certificates, Huntington's disease is the most commonly listed cause of death, with cardiovascular disease being a secondary cause. When you break that down into the immediate cause of death, the most common cause of death is then respiratory disease. It's hard when we're looking at basically querying large databases to try to extrapolate that to specific diagnoses or disease processes, but you could kind of posit that that would be related to dysphagia, which is a very common complication of progressive and end-stage Huntington's disease. So getting back to the multidisciplinary approach involving speech and language pathology early in the course of disease can be really helpful to identify early swallowing dysfunction and come up with strategies to try to alleviate that symptom. Another very common complication.
Along with dysphagia, there are other more proximate causes of death, such as weight loss and malnutrition, which may be related to the dysphagia, or they could also be related to the state of a relative hypermetabolism that these patients develop.
Adequate caloric intake is important. Finally, and this will come up later in our conversation, suicide is something that we as neurologists and our care teams have to be very aware of. The incidence of suicide is very high in this population compared to the general population.
So a lot of the symptoms that you mentioned are a lot of the symptoms that we don't characteristically think about patients who have Huntington's disease with their hyperkinetic and choreiform kind of movements, and then their progressive cognitive decline, but you focus on these symptoms of dysphagia, difficulty ambulating, and then symptoms more of depression. And we covered a lot of these symptoms last week with Dr. Travis Lewis. But as far as these symptoms go, what kind of progress has been made in the treatment of these specific types of symptoms?
I think this is a great point that you make. When we're looking at how we address some of the largest contributors to impacts on quality of life and sort of longevity in this patient population, we're generally not always seeing the motor disorder of HD. And as was covered in the earlier episode, HD is a multifaceted disorder. We can kind of consider it as a motor disorder, a cognitive disorder, and a psychiatric disorder. And so addressing those other symptoms besides the motor symptoms is very important. When we look at what's available to treat those symptoms, we kind of borrow from the available therapies that have been studied in those settings as those symptoms arise in the general population. So we're looking at all of the classes of antidepressants that we're all familiar with, TCAs and SSRIs being most common from that class, and then a variety of other therapies, chiefly the neuroleptic medications. In terms of great evidence base for those therapies, there hasn't been very much that's been done in the HD population specifically. We extrapolate the efficacy of these agents to this population, and that sort of makes sense. It's a little ironic in that it's a Mendelian disorder. We know the gene, we know the mutation, we know the mutated protein, we know the neuropathology. But in terms of connecting that to all the myriad manifestations that occur in this disease, we're sort of missing a lot of that middle ground. And so it's not unreasonable to think that those agents might not have the same kind of predictable effects and side effects and complications of therapy as they would in somebody who doesn't have HD.
For example, you may want to up-titrate someone's SSRI a little bit more slowly, or you may be more cognizant of medication interactions using dopamine or serotonergic therapies in this patient population. But when it comes to the pharmacologic management that you were probably thinking of when you came to this episode, you're probably thinking about managing the symptoms of the movement disorder, which we have the most evidence for.
When you look at, where do we have large size randomized class 1 evidence trials to sort of base our treatment decisions? We're mostly looking at things aimed at the motor disorder. And Huntington's disease is very interesting phenomenologically in that it can produce a huge array of different hyper and hypokinetic movement disorders, but the one that we're all most familiar with is chorea, and therefore that's the one that has the most therapies studied. When we're talking about the agents that have the greatest weight of evidence behind them, we're mostly talking about tetrabenazine and now in the last several years, deutetrabenazine. These drugs are both vesicular monoamine oxidase transport inhibitors, VMAT. So
VMAT, as you may recall from med school, is the presynaptic transmembrane protein that actively transports all your monoamines, dopamine, serotonin, norepinephrine, transports these back into the nerve terminal that originally secreted these transmitters. And by blocking the function of VMAT, by using tetrabenazine or deutetrabenazine or other drugs like MDMA or amphetamines, it restricts all those free monoamine molecules from returning to those presynaptic neurons.
So this drug is what we call a dopamine depleter. Deutetrabenazine has the prefix "dew", meaning it is deuterated.
So what is the difference between deutetrabenazine and tetrabenazine?
Right. So both of these drugs have been shown to produce a meaningful reduction in chorea. They're both measured by the Unified Huntington's Disease Rating Scale, which is a rating scale that has a number of different components to it, one of which is a motor rating scale. And so all of these trials will use the chorea subscore. Where we think the differences come from are that deutetrabenazine is deuterated, so its metabolism is slowed down somewhat. So this has a couple of different advantages. For one, tetrabenazine at its maximal doses of 50 milligrams a day, sometimes even up to 100 milligrams a day, has to be given in 2 to 3 divided doses. That can be fairly frequent for someone who might struggle with swallowing, might struggle with keeping to a dosing schedule. Deutetrabenazine can be dosed at a twice-a-day frequency, which is advantageous.
Another side effect, somewhat related to the slower metabolism of deutetrabenazine, is that it can be given at smaller doses, with a longer steady state and fewer fluctuations in serum concentration, with presumably less toxicity.
When we're talking about side effects to look out for when you start a patient on one of these drugs, for tetrabenazine specifically, patients can often report a new or worsening depression and potentially even an increased risk of suicide. which can be a grave limitation in using this agent in someone who has both depression and chorea.
For what it's worth, Deutetrabenazine has been reported to carry a lower risk of these side effects. It's also less likely to cause agitation, insomnia, and Parkinsonism, according to some indirect comparisons between the Tetra HD trial and the first HD trial.
So when you're choosing an agent to treat chorea, it's a treatment decision that has to be made considering the whole patient and their spectrum of symptoms. And so that means you're considering what is the impact of chorea on this person's quality of life? Is it meaningfully impacting their ability to accomplish things that they want to? If the answer is yes, then it warrants treatment. But because of the side effect with tetrabenazine and worsening depression, it's important to identify concomitant depressive symptoms. If they're present, you might be tempted to use another agent. So the other class of medications that historically have been used to great effect and still are in many cases would be the neuroleptics. So chiefly we're talking about the atypical neuroleptics and specifically risperidone and olanzapine.
And like any other neuroleptics, you worry about side effects like apathy, sedation,
extrapyramidal side effects, tardive dyskinesia,
QT prolongation, and predisposition to a ventricular arrhythmia.
And then particularly with olanzapine, a metabolic syndrome.
So deutetrabenazine and tetrabenazine are the mainstays of therapy in patients with HD, but there are a few other symptoms of HD that we try to provide some sort of targeted treatment towards, and kind of gets back to Huntington's disease being a disorder of movement. So kind of briefly, can you describe some of the other symptoms that we try to target with our therapies?
Yeah, so staying within the motor domain, like I mentioned before, there are a number of hyper and hypokinetic movement disorder symptoms that can arise. So dystonia is not uncommon in Huntington's disease, particularly as the disease starts to progress further. For focal dystonias, we can use Botox or braces as we would treat any other focal dystonia. For generalized or axial dystonic symptoms, we're again going to be a little bit more cautious with something like an anticholinergic or a dopaminergic agent, just because these patients are more sensitive to side effects of delirium or disorientation or, particularly delusions or hallucinations with a dopaminergic agent, but they're available. I'd say most people would probably use a low-dose benzodiazepine or even something like baclofen to treat uncomfortable generalized dystonia. For bradykinesia, amantadine and even levodopa-carbidopa have been used in some settings, again with caution. Tics can arise, and again, benzodiazepines, or in this case, SSRIs, or going back to the class of neuroleptics, can be helpful. And for myoclonus, again, looking at something like clonazepam, maybe a longer-acting benzodiazepine can be helpful. I'd say pain is a symptom that we don't always think of as being very characteristic of HD, but it can be common, and oftentimes it's related to these motor symptoms. So asking about pain, identifying it, and if you can identify the underlying cause, be it a movement disorder or some other process, treating it, starting like you would with anybody else with Tylenol or NSAIDs, or cautiously even an opioid medication if you feel like you need to.
So in addition to these cornerstone therapies that we have for Huntington's disease, what other kind of supportive therapies are patients typically offered?
Yeah, so because right now there's nothing that really targets the disease process itself, there have been a number of agents that have been studied for trying to reduce the symptoms of HD. And so a patient might come across a number of different things. We have the advantage to be able to refer back to guidelines from the AAN earlier in the 2010s, where they go through a number of these different agents. So they conclude that tetrabenazine and the neuroleptics both have good support. Deutetrabenazine was not available at the time of those guidelines, so that's not present. So once you get past tetrabenazine and the neuroleptics, there's a number of other agents that have been studied.
And specifically, Dr. Arati is addressing the drugs that may affect the choreiform movements of HD, but they haven't been shown to improve any other of the HD symptoms.
The evidence for these mostly comes from smaller, weaker trials with, nowhere near the kind of robust evidential support. Two of the agents that are sort of at the top of that list are amantadine and riluzole.
Amantadine, which is a mild NMDA antagonist and facilitates dopamine transmission, is used also in Parkinson's disease. And riluzole, which is a neuroprotective agent used mostly in ALS, that also blocks NMDA receptors, and it inhibits glutamate transmission in the central nervous system.
The AAN concludes that these can be considered, but I would say that they're probably not too often used in the clinical setting. Others that you'll see on that list are minocycline, the tetracycline antibiotic, nabilone, which is a synthetic cannabinoid, Sativex, which is a proprietary combination of THC and cannabidiol, also including creatine and CoQ10, which are some very frequent nutritional supplements. All of these agents had either very poor evidence and not enough evidence to make a recommendation, or were not found to be helpful.
So getting back to HD being one of the movement disorders, and there being a great deal of evidence that deep brain stimulation as an adjunctive therapy or even as a primary therapy in patients who have idiopathic Parkinson's disease or essential tremor, is there any evidence that deep brain stimulation could be effective in patients who have HD?
Yeah, that's a great question. So there are some studies, both case reports and one small case series that have been looked at. So a number of individual case reports have looked at the treatment of chorea with bilateral globus pallidus internus stimulation. And in each of those individual case reports, a treatment effect was identified. There was also a case report of juvenile HD treated with the same bilateral GPI DBS placement. And then right now, actually, in Europe, there's a German phase 2 study of bilateral GPI DBS placement. So this is an active area of study.
Okay, so maybe something kind of in the pipeline as far as like what we can offer patients in the future regarding deep brain stimulation. But in addition to that and to the more standard kind of pharmacotherapies for the motor manifestations of Huntington disease, what other aspects of the disease do we try to focus our treatment on?
So, when we go back and we consider HD as a motor disorder, a psychiatric disorder, and a cognitive disorder, we really have to take great care that we're giving enough attention to particularly the psychiatric disorder. What this really comes down to is, for you as the treating neurologist, maintaining great vigilance for depressive symptoms. And in particular, in this patient population, they may have atypical presentations of depression. They might have more predominant sleep disturbances, anxiety, pain, or fatigue. They may not always complain of a depressed mood. So something to be very mindful of is, again, this increased risk of suicide and suicidal tendencies. And this comes down to a couple of things. It's both making sure that you're inquiring about these symptoms when you encounter patients who you've identified depressive symptoms or any other red flags. It's making sure that you broach this topic in a very comfortable and non-judgmental fashion to try to make that patient feel comfortable discussing the topic with you. It's also remaining open to cues and even, independent reports by family members that they're concerned about behavior patterns that they're identifying, in their loved one. And again, this is something that can be common in this patient population, but it is something that can be treatable.
Now, Dr. Arati said these are common, these depressive symptoms, or at least some of these atypical signs of depression, signs like sleep disturbance or change in appetite or some sort of impairment in concentration, things you might even think are solely attributed to the neurodegenerative process of HD. But how common are these signs and symptoms? For a treatable condition that costs nearly $50 billion per year in disability in our country alone, depression is extraordinarily common in HD. According to observational data from over 50 sites in the US, in Europe, and Australia, nearly half of patients with manifest symptoms of HD will experience feelings of sadness, and a similar proportion of patients may endorse anxiety, with a quarter of patients having low self-esteem. So yeah, depression is a major comorbidity of HD. And whether it's related to the underlying neurodegenerative process of HD, or it's the mental consequence of knowing you have a terminal condition, it is something absolutely worth screening for and trying to treat early on. And besides these pharmacotherapies, what other kind of resources might you provide your patient?
Yeah, I think this is a really, really important question. And it gets back to the fact that the adequate and complete care of Huntington's disease involves both care of the patient and their family and their loved ones. This is a disease that affects entire families and multiple generations simultaneously. So to be able to meet all of their myriad needs, you need help as a neurologist. This is a disease that is most commonly and best served by a multidisciplinary approach. And so what that means is that you're going to be part of a care team that involves a number of other individuals and disciplines. And so most centers that you will look at will include a a neurologist, a psychiatrist, potentially a psychologist, social workers, physical and occupational therapy, genetic counselors, which are extremely important, speech and language pathology therapists, dietitians, nursing, research coordinators, kind of you name it. So, making sure that you're connecting your patient with these resources is very important. And sometimes that might mean that you're working in an academic center that has a Huntington Center or an HD Center of Excellence, or it means being aware of where these centers might be and making sure that you're helping to enable your patient to access those centers.
To find a list of these HDSA Centers of Excellence, go to hdsa.org and find the banner at the top of the screen that says About HDSA, and the drop-down menu will take you to the HDSA Centers of Excellence. As of the release of this podcast, there are currently 43 of these centers in the U.S.
And just about 3 or 4 years ago, there were only 20. So there is a huge push recently to try to mobilize resources for this patient population.
And as somebody who does not see a lot of Huntington's disease, my impression is that these things, these social and psychosocial and family dynamics that you focus your treatment on, and this kind of multidisciplinary care is a really critical component to it. But it may not have that same excitement to it that some of these newer and emerging therapies may have. And I think that a lot of people who are listening to this show would probably be quite interested to hear some of the latest research about some of these emerging therapies for Huntington's disease. So why don't you kind of take us in that direction?
Yeah, as you said, it gets to probably one of the more exciting domains in medicine in general, let alone neurology. So right now, in terms of disease mechanism modifying therapies, there is nothing that's available to patients, but that is very likely to change in the coming years. So I'll start with going through a couple of different classes of potentially disease mechanism modifying therapies. The first and most developed class of medications here would be HTT lowering therapies. So the mutant protein is called mutant Huntington protein. And so these are therapies that reduce the expression of that mutant protein. So these therapies really get at the sort of sine qua non of the disease. So right now, one class of these medications is what we call an antisense oligonucleotide, or ASO. These ASOs are small antisense ribonucleotide molecules that can target messenger RNA and, through a variety of different mechanisms, reduce their expression. So downstream, this prevents the production of the mutant protein and all of the consequences thereof. So right now, they just completed a phase 1/2A trial. It has not been formally published, but they've presented a number of their different results, which have been really exciting.
So let me jump in here and emphasize how cool some of these new data are. Like Dr. Arati said, just to be perfectly clear, these small molecules inhibit the messenger RNA that produce the problematic Huntington protein. Blocked messenger RNA, no abnormal protein. But to get this drug into the central nervous system, it has to be administered intrathecally. So let me show you exactly what the Ionis HTTRX trialists found in their study, which again are very preliminary results. In this first ever human trial of Huntington disease gene therapy, 46 patients were randomized 3-1 to receive 4 doses of intrathecal HTTRX, the ASO, or they received placebo. It was a phase 1/2A trial, basically looking at the safety and drug tolerability. Over the 4 months or so of monitoring during treatment, there were no adverse reactions to the intrathecal injections. By sampling the CSF, the investigators confirmed that the ASO remained present in the CSF, and they also found that there were significant dose-dependent reductions in the CSF concentration of the mutant HTT protein.
They're able to achieve a 40 to 60% reduction in CSF. In terms of the clinical outcomes...
And again, this is only preliminary safety data. But does this mean that there was any clinical benefit? I mean, we've seen similar molecular responses to antibody therapies in Alzheimer's disease without any major clinical responses. What's to say that these ASOs in HD are any different? Well, as it turns out, they may have some sort of clinical effect.
They've identified an improvement in the total motor score part of the Unified Huntington's Disease Rating Scale, as well as in the symbol digit modalities test. So again, these results have not been fully analyzed and published, but they're exciting enough that Roche has licensed the drug and is going to proceed with designing and executing a phase 3 trial.
I guess although it's not a safety concern, it's definitely kind of a treatment-related concern. And because these ASOs are targeting this messenger RNA, and this takes me all the way back to medical school, it's not like it's a curative treatment. It's something that will probably require repeated and continuous injections to maintain efficacy.
Yeah, that's true. When we have the preclinical studies of ASOs, we find that their dose effect of reducing expression is prolonged from single doses, but we don't know how long we can stretch that yet. It just hasn't been done. So right now, what we're looking at are monthly intrathecal injections, and that does carry with it some burden and risk of anytime you're accessing the subarachnoid space there.
So in addition to using ASOs, are there any other methods of gene silencing that are out there?
Yeah, so the general family of therapies that includes ASOs is more broadly called RNA interference. And there are other molecules, small molecules, that are used to accomplish the same things that work in slightly different ways. So these would include things like small interfering RNAs, for instance. In addition to which small molecule you're using, probably one of the bigger questions about this therapy is the delivery to the central nervous system. And so the therapies that we talked about that are being actively studied right now are intrathecal injections, but there are other ways that are being studied on a preclinical basis right now. A common method is using an adeno-associated virus vector and taking that vector and using a stereotactic injection to introduce it directly into the brain, most commonly right now in animal models, into the basal ganglia directly, and having that vector produce the small molecule that you would like to exert a therapeutic effect. Other delivery methods that could be explored include even nose-to-brain delivery. So the olfactory bulbs and terminals can avidly bind certain small molecules and transport them widely throughout the brain, and even some small molecules directly into the basal ganglia. And finally, the CRISPR-Cas9 mechanism has also been studied on a preclinical basis in HD.
CRISPR-Cas9 refers to the targeted genome editing using the Streptococcus bacteria protein, CRISPR-associated protein 9 nuclease. What investigators hope to do by hijacking this bacterial machinery is that they can simply remove or recode those triplet repeats in chromosome 4, causing the pathologic Huntington protein. Unlike the ASOs, which require repeated injections, using the CRISPR-Cas9 gene therapy, it'd be more of a one-and-done kind of treatment, as long as they could get it to work. Other emerging therapies include certain monoclonal antibodies.
A monoclonal antibody directed towards something called semaphorin 4D.
An antibody that specifically targets inflammatory pathways in the central nervous system. Then we've got drugs that act by shuttling energy substrates to cortical neurons. Drugs like triheptanoin oil.
Metabolism. And so this therapy, this triheptanoin oil, basically is a triglyceride that provides direct intermediates for the Krebs cycle.
Which has the potential to improve the metabolic efficiency of dying neurons. And lastly, of course, we've got our stem cells.
And finally, there's a phase 2 trial that's recruiting in Brazil that's looking at intravenous injection of mesenchymal stem cells.
So a lot of interesting stuff in the pipeline, but as it stands right now, a lot of therapies are kind of aimed at the patients and their families and their providers to kind of improve the quality of life, improve the symptoms, but not necessarily to cure the disease.
Yeah, I would agree with that. I think right now it's a very exciting time in the HD world and really in neurology in general, because a lot of these therapies are applicable to other disorders that we see and treat. But yeah, as you mentioned, the cornerstone of caring for these patients and families is making sure that we have a really robust care network and that we're connecting them with resources that they need in multiple domains.
So there are lots of things to look forward to, and already so much progress has been made. With that, I think that we're going to call it a wrap. That's all we've got for the program this week. Huge thanks to Dr. Stephen Arati for putting together this week's program and for teaching me all about the emerging therapeutic options for patients with HD. And if you want to continue your medical education using brainwaves, take a listen to something else from our archive, or follow us on Twitter at Brainwaves Audio. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music for this week's program was courtesy of Mike Durek, Jesse Spillane, Lee Rosevear, Jason Shaw, and Dr. Turtle under a Creative Commons license. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler. Thanks for listening.